That's a very tough decision, especially in first line. I mean, we are taking into account on one side CLL-related features, including presence or absence of TP53 aberrations, immunoglobulin G mutation status, but on the other side, we should also take into account relevant comorbidities and, of course, patient preferences. So we have to balance some pros related with the administration of continuous BTK inhibitor on one side that are generally well tolerated and can be taken orally as continuous treatment. On the other side, nowadays, as fixed duration regimen, we have in Europe the combination of venetoclax plus obinutuzumab, and the cons is related with the IV administration of obinutuzumab, but it's a 12-month duration regimen. And recently also the combination of venetoclax plus ibrutinib was approved and is available as fixed duration treatment in many countries in Europe. So basically the most relevant factors in driving the treatment choice at the beginning is the presence of TP53 aberrations. If patients are carrying TP53 aberration, I would generally go for a continuous treatment with the BTKI. Unless more solid data in the next future with the combination of venetoclax plus ibrutinib are suggesting that we can achieve long-term disease control with this combination even in this very high-risk category of patients. Otherwise, for patients carrying unmutated immunoglobulin genes and or mutated immunoglobulin genes, I would consider both options and discuss with the patients the most convenient scheme or design.